know that sites of metastasis are prognostic of overall survival in patients with prostate cancer. There was a meta-analysis involving around 9,000 patients with metastatic castration-resistant prostate cancer, which was done by Dr. Halabi and published in JCO. So basically, this meta-analysis looked at patient-level data from 9 phase 3 clinical trials for patients with mCRPC who were treated with docetaxel. And what it found was that patients who had metastasis to only lymph nodes had very good survival, which was followed by bone, followed by lung, followed by liver. And each of these subsets of patients were having progressively worse survival. But we do not know what is the underlying reason for this phenomenon. So we looked at a large real-world database to investigate the molecular and tumor microenvironment characteristics of patients based on their sites of metastasis. So in this, we had around 6,064 patient samples. 56% of the samples came from primary prostate, 14% and 13% came from lymph node and bone respectively, and rest sites contributed 17% of the samples. We did a multi-pronged approach in genomic testing, which included targeted genomic sequencing as well as whole exome sequencing. We did a whole transcriptome sequencing, and then we also looked at various signatures for androgen receptor and neuroendocrine prostate cancer score. And we also looked at immune cell fractions based on whole transcriptome sequencing data. And multiple interesting things came as a result of this analysis. It showed that in terms of the genomic markers, so different sites of METs have different mutations. For example, liver was found to have more RB1, AR, and APC mutation, and there were less SPOP mutations as compared to primary prostate cancer. However, lung METs, they had more SPOP mutations, KRAS, PI3CA, and BAP1 and APC mutations. When we looked at ARV7 alterations, they were much more in all metastatic sites as compared to primary prostate cancer. We then looked at gene signature patterns, and there we found that metastatic sites such as liver had AR's signature and MAP kinase pathway signature. So RNA signature scores also differed per sites of metastasis. Compared to primary, liver MET showed lower AR signaling MAP kinase activity, T cell inflamed and interferon-γ signatures, but they had higher neuroendocrine prostate cancer scoring. When we looked at the lung METs, they had lower AR signaling score. When we looked at the tumor microenvironment, we again found multiple differences between primary prostate cancer and sites of METs. For example, tumor microenvironment of liver METs was less enriched with macrophages, M2, B cells, natural killer cells, neutrophils, and Tregs. In contrast, for example, lung, it was less enriched for natural killer cells, but it was more enriched for Tregs, meaning T regulatory cells. And then we also looked at pathway enrichment analysis based on gene set enrichment analysis. And it showed that E2F, G2M, and MYC target pathways were more upregulated or enriched in visceral and non-visceral sites as compared to primary prostate cancer. So to summarize, our study showed that in primary prostate cancer, metastatic sites such as liver and lung had significantly different molecular alterations, RNA signature scores, and tumor microenvironment immune infiltrates. Metastatic sites were similar in tumor mutational burden and DNA mismatch repair or microsatellite instability high. However, there were multiple pathways which were significantly upregulated or downregulated in visceral and non-visceral sites as compared to primary prostate cancer. So these findings may advance treatment of prostate cancer by providing insights into the biology of metastatic tropism and help with future drug development.